Next up is Pearse Keane. He's going to tell us about swept source OCT angiography of exudative age-related macular degeneration.
It's a great pleasure and honor to be invited here to speak about swept source OCT-A findings in AMD. So kind of a broad title for the talk, but I'm actually going to narrow things down just a little bit. First of all, I should say that these are my disclosures. I'm a consultant ophthalmologist at Moorfields. I'm also an NIHR clinician scientist at UCL, and these are my financial disclosures. I also want to highlight the contribution of Samantha Mehor, who I see in the audience, who's the ophthalmic photographer at Moorfields, who probably has the most expertise in using the Triton swept source OCT-A. So if I show some nice images, it's probably her that's taken them. So I thought it might be fun for my talk, given that it's supposed to be a 12-minute talk, to start at the end and start with the conclusion slide and just actually say what are my thoughts about the real-world clinical use of OCT-A in AMD, given that we've had these devices from multiple different vendors in Moorfields for probably about 2 years now. And so what my thoughts are, and I'm open to contradiction or open to further kind of ideas on this, but my first thought is that in people who are elderly, with very poor fixation, who have multiple pathologies, a lot of mediopacities, etc., I think it's fair to say that OCT-A still has some further work to do. Although I would say it seems like every few months there are massive updates in the software for these devices. So things are not standing still. But what I would say is that where I think it's really useful in the context of AMD, or CNV if you like, is firstly in early AMD. So the type of patient who comes to your clinic, comes on a Friday late afternoon, evening, visual acuity is 20/20, they've got dry AMD which you're monitoring, and you're about to leave for the day, and you happen to look through the scans and you see a very tiny little cyst, and you think, oh, do I need to do a fluorescein angiogram, or what do I do? Or in the UK, you're not able to treat those people because their visual acuity is too good. What I found is that in that scenario, an early AMD query CNV development, OCT-A is fabulous. The other thing that I think is well acknowledged now at this point is that in non-AMD CNV, OCT-A works really nicely. Your myopic CNVs, your inflammatory CNVs, I think it's really quite robust. And then lastly, and perhaps the area that I'm beginning to depend on it more and more, is equivocal fluorescein angiography findings. So if I have a case where I know in advance that even before I order a fluorescein angiogram, that the findings may be difficult to interpret, I find OCT-A to be very useful. So a prototypical example of that would be chronic central serous retinopathy with a big area of sick retinal pigment epithelium that you know will show some kind of hyperfluorescence, and is it CNV, is it not? OCT-A is brilliant in that scenario. Or in cases of inflammatory disease, punctate intrachoreidopathy, multifocal choroiditis, etc., is this an inflammatory focus or is this a CNV? In my experience, OCT-A is very good in that scenario. Now, that's the conclusion, but I'm going to spend the rest of my talk talking about why I think OCT-A is most interesting. And I believe it's because it allows us to try and gain new insights into the disease processes. And in particular, I think it allows us to look into something called subretinal hyperreflective material, or often you'll hear it described as SHREM. So I've got 6 cases that, depending on how slowly or how quickly I talk, we can get through some or all of them during my time, just to illustrate that. So the first case here's a fluorescein angiogram which shows a sort of a typical classic CNV. We take an OCT through the lesion. And I think it's fair to say in recent years we've begun to focus a lot more, to move beyond just fluid and to look at this material in the subretinal space that's hyperreflective, subretinal material. So my question is, what is that material? And there are a few different options about what it could be. And I think the most sort of initially seductive option is that it's just the CNV membrane, that this is a type 2 CNV in the subretinal space, and that's what this is. But of course, is there an element of fibrosis in these cases, or exudation, subretinal hyperreflective exudation, blood, vitelliform lesions, reticular drusen, etc., etc. There's lots of other options for what it could be. Now, why is this interesting? Well, I would speculate, and I think it's fair to say it's speculation, that if we were to look at something like the recent disappointing results from Fovista, which did not meet its primary endpoints, I would hypothesize, and I'm interested to hear other opinions, that maybe it was related to the inclusion criteria in the trial and the definitions of subretinal hyperreflective material and lack of our understanding of this OCT finding. So let me quickly go through some cases. So I've got a 77-year-old woman, Irish nun. Any patients who come to me in Moorfields who are Irish, I always make a note that they're Irish, and I make a note of which village in Ireland that they're from and give them special treatment, because that's where I'm from originally. So if you hadn't guessed from my accent. So decreased vision in her right eye, vision is 6/12. Here's the color fundus photograph, maybe some subtle changes. We perform a fluorescein angiogram, and it seems to say, I mean, I guess possibly a minimally classic lesion. So there's some stippled hyperfluorescence, and then one small focus that maybe you would say is a classic component. We take a typical spectral domain OCT through it, and we see this picture that we're kind of expecting, which is that there's some perhaps fibrovascular PD and then some subretinal hyperreflective material above it. We do angio-OCT, and it shows us what looks like a membrane. But what I find really useful with angio-OCT is to turn on the angio-B mode, to superimpose the flow on the image. And what we can see is the red here is the flow in the subretinal space, and then a purplish, a bit less obvious flow in the sub-RPE space. So essentially, we're using OCT to dissect out the different morphologic compartments of the CNV. Okay, another Irish woman, the last Irish woman in my talk, 84-year-old woman, difficulty reading, visual acuity 6/9 and 6/12, so borderline in terms of the UK NICE criteria for treatment. And we take this, we see this OCT, and if you look carefully, you have this outer retinal hyperreflective focus that is, of course, suspicious for retinal angiomatous proliferation with the intraretinal fluid. Now, I would say that I've had some mixed results in terms of using OCT-A in RAP, but we did a fluorescein angiogram which was suggestive of an early stage RAP lesion, and we performed OCT-A, and what you can see up here is a very tiny little hyperreflective area, but not very impressive. But what's interesting is that if you correlate the angio flow, you can see a lot of flow in this region and not associated with a projection artifact in that space. Next case, 81-year-old man who's developed wet AMD in his left eye. He's had 11 anti-VEGF injections. Visual acuity is 6/9, so he's doing pretty well. And we can see on the color fundus photograph there's this whitish lesion. So is that presumably some fibrosis, or could it be something else like dehemoglobinized blood? We can see on the wide field OCT this hyperreflective foci. We can see a sub-RPE component as well. We do the angio-OCT, and what's striking to me is the lack of flow in this subretinal hyperreflective material. If you look on the chorea capillaris, there's a sense that there may be something happening underneath. And when you manually tweak some of the segmentation findings, you can see here that actually you can see this membrane at this deeper level beneath the subretinal fibrosis. So really interesting to think about the implications of that. Fourth case then, 76-year-old woman, central blobs in her eyes which gradually fade, normal visual acuity. She comes to us in August. She's got drusen, no treatment instigated. She comes back to us in January, so hot off the presses with blurred vision in her left eye. Vision is down to 6/24. And lo and behold, she has developed something. She's got this fibrovascular PED with the subretinal hyperreflective material. We do a fluorescein angiogram, which shows us this very bright early hyperfluorescence, which leaks profusely in the later frames with stippled hyperfluorescence surrounding it. So we're already thinking, what is the OCT picture going to look like? What's interesting was that it didn't look like a very obvious sort of network that you see, but you saw this area here and this area over here. We look at the flow image and nothing very, very impressive on the subretinal hyperreflective material. But if we target it to specific locations, suddenly, wow, what is this? This very, very active flow in this lesion corresponding to that small area on the scan, plus some sub-RPE flow over here. So really beginning to disentangle and dissect these features. And so then my last, I believe my last case, 70-year-old man, incidental finding. So what happened was he's a guy whose brother was diagnosed with some sort of eye tumor, and he decided he'd go for a routine checkup. He's completely asymptomatic, and he's got 20/20 vision. And what we see on the fundus photo is this grayish lesion just supratemporal to his fovea with some pigmentation there. On the OCT, we see some fluid, and we see this subretinal hyperreflective material. Now, the assumption that I had made was in this case that this guy would have an extrafoveal classic CNV. So I was interested then to look at some of the imaging. We performed fluorescein angiography, no early fluorescence consistent with that, with the classic CNV, but these two little foci, hyperreflective foci, and then at the late frame, some leakage from those with maybe some stippled hyperfluorescence around it. And so from looking at that, you're scratching your head, is this a RAP lesion? But the OCT doesn't really look like that, at least to me. And I'm certainly open to alternative opinions on that. And so we do the angio-OCT. And again, what's striking is as we scroll through the subretinal hyperreflective material, we're not really seeing any convincing flow that we can't attribute to projection artifacts. So we're trying to figure out what's going on. Is there something subtle in the sub-RPE space in this case? I do notice that there's perhaps a dilated choroidal vein underneath, and it just makes me wonder, from speaking to people like Kunal Dansingani, is this a pachychoroid neovasculopathy? Could this be a type 1 membrane complicating that? So to conclude then, and I'm conscious of the fact that I pretty much always go over time in talks and get cut off abruptly, is that I think that one of the most exciting things for us to do in OCT-A is to look at SHREM, to look at subretinal hyperreflective material. And I think that SHREM is a mess at the moment, and I think that OCT-A is going to be the key to disentangling that. Now, that's not a unique idea that I've come up with myself. This is an idea that people like Kunal and Dr. Spade and others have been publishing on in recent times, and I certainly encourage you to go out and read some of those papers on that. And then lastly, that's my email address. If you have any cool images, OCT-A images that you don't know how to interpret, I'd love to get them. Thank you very much.